Welcome, everyone. My name is Sue Full, and I'll be your hospitality host for today. You have joined Living Your Best Life Post-Transplant. And now to get started, I'm very pleased to introduce Dr. Naeem Issa. He is a transplant nephrologist and consultant at the Mayo Clinic in Rochester, Minnesota. He trained in internal medicine and nephrology at the Cleveland Clinic in Ohio and transplant nephrology at the Mayo Clinic. His primary interests are kidney and pancreas transplantation, living kidney donation, and kidney paired exchange. Dr. Issa, it's my pleasure to turn the presentation over to you.
Thank you so much. I'd like to thank you for the kind invitation by the PKD Foundation. Thank you all for joining this webinar about an important subject that I'm really excited to talk to you about. So some disclosure, nothing to disclose. The only disclosure I have that I'm a transplant nephrologist at the Mayo Clinic in Rochester, Minnesota, and I don't have any off-label or investigational uses. Okay, so we'll discuss today what life is like after kidney transplantation. Most patients with advanced chronic kidney disease or those on dialysis get a lot of education regarding the pre-transplant workup, and really no one really actually tell them what really happens and what to expect after kidney transplantation. In fact, most patients have different expectations in mind on what will happen post-transplant that are really very different from what the reality is. So I'll provide you with a brief overview of the kidney transplant benefits, what to expect at the time of surgery. We'll go over some of the things that you as patients and your family should expect after successful kidney transplantation. We'll cover the physical challenges that patients face after transplant and the role of immunosuppression. Very important, the emotional aspects of kidney transplantation that some patients do not realize this is a very large part of caring for kidney transplant. And talking about the financial aspect, there are some new changes in Medicare and the laws here in the US and what to expect about after transplant. And we'll touch also upon how your new normal will look like as you're not anymore on dialysis or you don't have chronic kidney disease. And at the end, we'll provide you some tips and some advice when you need to consult with your transplant team or come back to the transplant center. So why kidney transplantation? You know, it's cliche, we keep saying it's standard of care for end-stage kidney disease. I think the most important benefit of kidney is the mortality benefit and the survival benefit, in fact. Unfortunately, mortality rates on dialysis, taking all newcomers, that includes diabetics and a lot of patients who come to transplant with a lot of burden of heart disease and such and diabetes, is about 60% at 5 years. And kidney transplantation really prolongs your lifespan. It improves your quality of life. You can return back to work. You can return to the workforce, engage in exercising. And the most important thing is early referral. If you're a PKD patient, it's very important to know that you should be referred early. Your GFR start to be less than 30, in low 20s. This when you should be considering being referred to a transplant center, so you can be listed and start accruing waiting time. And typically, we recommend preemptive kidney transplantation as we have the best outcomes. So the mortality on dialysis is really higher than some common cancers, like colon cancer, kidney cancer, breast cancer. It's actually about 60% mortality at 5 years. When you look at kidney transplantation, it's based on some estimates. Recipients of kidney transplant had about 2.5 times more remaining years of life than remaining on dialysis. For example, if you're a young patient with 35, you need a kidney, you go into dialysis or you're faced with renal replacement therapy. If you get kidney transplant, your average lifespan actually on dialysis 12 years, and if you get kidney transplants up to 32 years or more. So that's why we offer kidney transplantations, not just ditching dialysis. Dialysis is good in terms of keeping people alive, but unfortunately, especially in the US, the outcomes of dialysis remain dismal. Unfortunately, not everyone is a candidate for transplant. Therefore, it is important to go through the evaluation of the transplant center. It's not a cure for kidney failure, because you still have to do blood work, you still have to take medications. But in general, most patients with kidney disease benefit from transplant. Like anything in medicine, we say there are no guarantees. The organ, especially if it's a deceased donor, may never work. It's extremely rare, but you can face primary non-function. You can get a high risk for infection and rejection. We'll talk about that. And the original kidney disease, not in the case of PKD, actually can recur on the kidney transplant, especially if it's a glomerular disease. Freedom from dialysis constraints, very important. Increased feeling of well-being. Basically very few restrictions in your diets and your activity. You'll feel better with kidney transplant. As we talked about, you live longer with better health, and you can engage in exercising. And very important, for women who are at childbearing age, they can get pregnant after transplant within certain criteria. More importantly, the medical complications that occur when you have end-stage kidney disease typically reverse or get better. For example, blood pressure control in most patients actually get better. In some patients, actually, we see higher blood pressure after transplant related to the use of medication or other etiologies. Anemia control gets better. You no more need IV iron or oral iron or erythropoietin. You ditch phosphate binders. Your bone disease gets better with transplant. And as I said, there are less dietary restrictions, such as in terms of phosphorus, potassium, and such. So what happened at the time of surgery? Your native kidneys are actually in the back. So we typically, they're very, very well protected by the rib cage. So it's very hard to get to them. So we don't really typically remove them at the time of transplant. And the new kidney, as you can see here, it's implanted in the pelvic area. The ureter is connected to the bladder, and the vessels are connected to the lower extremity vessels. Now, for patients with polycystic kidney disease, we in general do not remove the kidneys. But for some patients with polycystic kidney disease, we have some indications to remove the kidneys or perform what we call bilateral or unilateral nephrectomy. When the kidneys are extremely large, when they're really symptomatic, meaning they cause a lot of pain. Some patients come to us and saying, they're dependent on painkillers. They cannot function because of the pain. They're depending on opioids. Sometimes there is also a problem with early satiety, cannot eat. So that's an indication to remove the kidney. If we need a space, if there is no room to put the kidney, if those kidneys very enlarged and protrude in the pelvic area, the surgeon typically can tell you, we do an imaging study at the time of evaluation to know whether there is space to put a new kidney. Rarely, if the cysts are chronically infected, there is indication to remove them. If there is cystic bleeding that we cannot control, sometimes there is suspicion for kidney mass or kidney cancer. Now, the good news, the cysts that come with polycystic kidney disease, they never become cancer. However, over time, some people, and we saw that there is coexistence of solid mass among the cysts, and that can be done on imaging. And at times, actually, we have seen patients when we remove the kidneys, we did not know they had the kidney cancer at the time of transplant, and we discovered it's a rare occurrence, but there could be sometimes a coexistence of kidney cancer among those cysts. Sometimes those cysts drive blood pressure. They can be breast or kidneys and very hard to control the blood pressure. So within some some criteria, we remove the kidneys just to get better control of the blood pressure. Now, most transplant centers perform bilateral nephrectomies. They wait 6 to 12 months after transplant before they remove the kidneys. Sometimes they remove one kidney at the time of transplant and remove the other one after a few months, after everything is stable post-transplant. What we do here, what's particular about our Mayo Clinic program, and you get people from all over the US and the world, actually, we have a minimally invasive surgical removal through laparoscopic surgery of the polycystic kidney at the time of transplant. And we have performed actually almost 100 of those so far. So you can actually get rid of the large kidneys that are symptomatic at the time of transplant. You don't have to be subjected again to anesthesia and another surgery and be under the knife in a few months after your successful kidney transplant. So what to expect at the day of surgery at the hospital? It's about 3-day hospital stay. We focus on education and education. Learning the medication is very important. Can be overwhelming. Every member of the team will be focusing on giving education, when to time the medication and such, and the blood work. In the early post-transplant period, when we dismiss the patient to the immediate transplant clinic, we prepare them to be dismissed to home, provide a lot of education, a lot of classes. It's very critical to assure the best outcome. And we partner with your local physician, your local nephrologist. We tell most patients to really keep their local nephrologist so we can team up with them. And the patient becomes, the transplant center patient for life. So it's a partnership among 3 partners: the local physician or nephrologist, the recipient themselves, and the transplant center. And we observe the best outcomes when people comply with post-transplant protocol. It's very well protocolized. We'll talk about that in a second. What to expect in the first few days after your dismissal from the hospital. You may actually do daily labs, especially if you receive a deceased donor kidney transplant, did not kick in, or you still need dialysis. Then we phase out the blood work and checking, trough levels for some of the medication. We continue with intense education because the first year is actually very important. And once you pass the first year, the higher, because it has higher rejection rate, you can sail fine after that. So there are certain complications early on in the first week or so. Delay graft function from a deceased donor, typically about 20% chance. You may still require short-term dialysis. Sometimes there may be some technical issues, especially in people with polycystic kidney disease, especially if there's no room to put the kidney. Sometimes develop some fluid collection near the kidney transplant. You call it the lymphocele. There could be a wound, incision issues. I can not say more about rejection. Rejection, always we think about rejection. Having a kidney transplant thrombosis or clotting, the kidney can clot off. They're extremely rare occurrence, happen less than 1%, but can happen actually, and people may lose the kidney transplant early on. We focus on screening for infection, and we take every symptom very seriously. There are some late medical complications. Acute rejection always can happen, even several years post-transplant. So we keep checking labs and intervals. Chronic rejection, when the body keeps actually tackling the kidney and also rejected, therefore it's important to take the meds. We screen for certain viruses that can come. For example, in the case of BK virus, that's particular to solid organ transplant, especially kidney transplant recipients. It's a virus that does not cause any symptom, no fever. We keep screening for it in the blood because it may actually go to the kidney, the new kidney, and when it's there, your immune system will fight it, cause similar to a rejection. A lot of inflammation in the kidney, and some people may lose the kidney transplant from BK. The monoviruses, we screen for them, especially if you get a kidney that has CMV. cytomegalovirus and you did not have that before, you're not seropositive. We pay special attention for recurrent origin disease. As I said, polycystic kidney disease does not recur because the new kidney does not have, the mutation that caused the cyst. So that's a good thing in polycystic kidney disease patients. We keep screening for diabetes. Some of the medication can be diabetogenic, such as the tacrolimus that we use. So that's something that we take very seriously. And of course, we recommend to continue your health maintenance exams as similar to the general population, and that certain things that we screen for example, a derm appointment every year, because there are some increased risk of some certain skin cancer like women's cell cancer and transplant recipients. We focus in the long-term medical follow-up on the cardiovascular health, and I cannot really stress more about that. The reason is a lot of people come to transplant with the burden of chronic kidney disease, dialysis. They already have calcification in their heart vessels. They had issues with blood pressure for a long time. They have hyperlipidemia and such. So cardiovascular health is very important. We take it very seriously, check the blood pressure, lipid management, if we need to use a statin or not, encourage people to continue with good nutrition, avoid weight gain, glucose control, and people have diabetes before and after the transplant. And very important, the compliance with the anti-rejection medications, doing your lab draws on time, appointments. Certain transplant centers like ours, we do protocol biopsies, and that has been shown to keep the kidney going for a long time. Sometimes rejection can be silent, and we can discover rejection that's happening. We call it subclinical rejection before it becomes an issue and cause the loss of the kidney transplant. So we'll discuss the physical challenges. Most patients and their family would have questions about how the recovery look like post-surgery. I tell patients that your physical health before the transplant really dictate and predict your physical well-being after the transplant. Some patients who come to transplant were on dialysis. They know how dialysis is. It's a full-time job. It's very exhausting. Most people spend their day on the dialysis unit. They get wiped out when they go home. They can't do much other than sleeping. So at the time of transplant, we use actually certain scores. We imported that Karnofsky performance scale or score from oncology. And it's being now used across the boards in all types of solid organ transplant. We categorize patients according to a score. If you see 100%, meaning that you have a normal, you're normal, you don't have any constraints, meaning you can carry your normal activities without any restrictions. So we have cutoff that we use to accept people for transplant. It's very important, again, if you're independent, the more independent you can be with your daily activities, and the more you can give yourself self-care before the transplant, the best you do after transplant. So after transplant, it's very, very important to keep yourself well and active. Okay, many patients ask, what about pain post-surgery? The good news, it's brief. Tell you the truth, kidney transplant is not a heavy surgery. Yes, you will have an incision, but typically we taper the IV pain medications to oral medications within 24 to 48 hours. Most patients actually, even after a couple of hours of coming from the surgery, they can actually have sips of water, ice chips. We encourage them actually to get up and move early post-surgery. And those who do that actually have less pain, and the healing process is typically very smooth. As I said, kidney transplantation is not really a major or heavy surgery, as you can or may imagine. So the next challenge that you may face is the change in weight. Initially, most people actually on dialysis, they know the dry weight, their estimated dry weight. And you notice immediately after surgery, we pour a lot of IV fluids uh, to keep the kidney well hydrated, to make sure it's well perfused. Definitely your dry weight may be higher, especially when you leave the hospital, but the good news, the weight come off, the fluid weight will come off over the next several days because the new kidney will start urinating all the fluid out of your body. So that's a good thing. Now, what we worry about is the weight gain that comes after the transplant, in the first year. And on average, actually, I would not surprise you, some patients can gain up to 30 pounds in the first year. Why is that? Because your appetite is better. You do not have those kidney toxins that suppress your appetite. People tend to eat more as food tastes better after transplant than when you had kidney disease. Most of the restriction will go away. So you have to be really careful because weight gain can predispose to diabetes, high blood pressure, and other complications. So I tell people it's preferable to learn the habit of exercising before transplant, healthy diet. We all tell patients that staying active before and after, um, mitigate those complications, the weight gain. As you can imagine, the steroids we give, some people remain on low dose of prednisone that increase the appetite. So sometimes it's no one's fault, just, everything is happening, food tastes better, medications, side effects, and people tend to gain weight. And actually, I had instances when I saw someone at 2-3 months after transplant, I see them after a year. I could not recognize them from the so much weight that they gained in between. So that's something you should keep in mind. I tell people if you exercise before transplant, you engage in minimal exercise, 10-15 minutes per day, 3-4 times a week would be enough actually, and better than nothing, along with being careful with your caloric intake. Okay, so what about the role of immunosuppressive or anti-rejection medications? Our body is designed to recognize and fight anything that doesn't belong to us, right? Similar to fighting a disease or an infection. So we are built, our immune system is so robust to recognize non-self entities and attack it and kill it. And that's what rejection is. As you know, the kidney organ can come from either a deceased donor or living donor. That actually, even if you have a perfectly matched living donor, a sibling who could be your donor, you are still genetically different, and therefore we need to use immunosuppressive medication. At the time of surgery, we give IV induction. We call it induction immunosuppression, IV medication. Basically to wipe out all your fighting cells so they don't attack the new kidney. And then later, actually at time of day zero, post-transplant, put you on 2 oral medications. We call it maintenance immunosuppression, and that's for life and for the life of the kidney transplant. Those medications need to be taken for life and cannot be stopped. So that's the common combination of immunosuppressive regimens. Typically the primary agent is tacrolimus or Prograf. Sometimes we use cyclosporin, a cousin of it. There is new medication called IV belatacept IV. It's actually given every month as an IV. A second agent typically is Cellcept or Myfortic, those 2 medications. And the good news nowadays, in about 80 to 90% of patients, we don't use long-term steroids. Our center here actually use steroids in selected patients. As a PKD patient, you don't need to be on steroids unless there is actually some other issues such as autoimmune disease or other things superimposed that you need to stay on prednisone. So the main combination, I said, tacrolimus, mycophenolate mofetil, MMF plus minus prednisone. We talked about the new agent. Some people like to do it. It's once a month, so it requires setting this up in an infusion center. And why we use more than one medication? Because the immune system is so robust, it keeps rejecting the kidney, and each medication works at different part of the immune system. This is why we combine medications so they can keep the kidney safe from being rejected by your immune system. The strict adherence to medication is extremely important. It is important not to miss any single dose of the medications, because even sometimes missing one dose or get the habit of missing, the evening dose here and there can predispose the kidney transplant to be rejected. So very important to follow the instructions given to you by your transplant coordinator, your transplant specialist. And in fact, most rejections are silent. A lot of times, we out of the blue, someone we're following the labs many years after transplant, we see the creatinine rising. We call the patient, what's going on? They say they're compliant with medications. Sometimes they admit missing here and there. We get worried. We tell them to hydrate. We repeat creatinine. If still high, we invite them back to come to the transplant center. And we may actually, that may by someone to do a biopsy to rule out any underlying rejection. Some medications have to be really taken strictly every 12 hours, like tacrolimus or any calcium inhibitor or cyclosporin, because we dose them according to blood level in the blood. It is a lot of work to follow those instructions, doing the blood work on time, but at the end, your kidney transplant live longer and provide you with better health than, overall than being on dialysis. Those medications are not devoid of side effects, like anything. They keep you healthy, they keep the kidney healthy, but they have some side effects that you should be aware of, because sometimes I've seen it in many instances. Patients tell me, "Oh, no one told me that I will have a tremor with tacrolimus, or I lose my hair." And I have some people, some ladies who lost almost all their hair with tacrolimus, and it's actually something very serious. Sometimes it can be just a mild problem. Hair growth with cyclosporin, and of course, those medications increase the risk for infection. They can cause some disturbances in your lipids. Your cholesterol can be high with some of those medications. Tacrolimus is known to be diabetogenic, especially in people who are overweight. Pre and post transplant, the middle-aged patients can be can have post transplant new onset diabetes. And some of those medications also can elevate the blood pressure. As I said, in most people, we ditch some of the blood pressure medication or no medication, but in some patients, we still need to give blood pressure medication. It's very important, if you experience any side effects, do not stop any of the medication on your own. If prednisone giving you side effects, if mycophenolate mofetil giving you GI symptoms, or do not just call your transplant coordinator, call your doctor. Don't stop it on your own. We typically get those. We're very, we have alternatives. We can adjust the dosing, we can make changes, a lot of adjustments, so you can have no side effects. So be careful not to stop any of those medications on your own. Okay. So we talked about you have responsibility as a patient. So it should be an expectation. Take your medication on time as prescribed. Get your blood checked routinely. I tell people, if you know a couple of things, you don't have to really worry about many things, because just your creatinine level and, know what's your baseline creatinine. And if it goes up, just be alarmed. What's the tacrolimus trough level target? For example, if we say 6 to 8, if you see it, really low, that predisposes you to rejection. So that should alert you to talk to your coordinator to adjust the medication so you don't get rejection. Because sometimes, in a lot of transplant center, we care for 3,000-4,000 transplant patients. So the lab value may not come on time. So be your own advocate. It's very important. Come for your follow-up appointment and always keep your nurse coordinator aware of what's going on. Now, there are some emotional issues and aspects of kidney transplantation that come after successful kidney. An extremely important aspect that no one really will bring up with you before the transplant. So we'll talk about it. You know, I mean, who doesn't have some underlying, at times you get anxious, you have mild anxiety, depression. If you have any underlying mental health issue like mild anxiety, depression, these things can worsen immediately post-transplant. You know, the stress of surgery, the stress of travel to the clinic, the stress of, arranging for rides. It's not a fault of your own at all. You know, the medication themselves, we talked about the steroids and high dose steroids that we give at the time of transplant can also cause some disturbance of your mental health. So it's very important if you have an established relationship with a psychiatrist or counselor to keep that in place. If you don't, we refer you to someone after transplant. Also, as I said, the stress of surgery itself, I cannot really say that. Some people say fine, but that's something you should be aware of. And close follow-up is essential to maintain stable mental health, especially if you deal with complications. You know, complications can happen to anyone, even if you're the best compliant patient. So be ready, have that mindset that things may happen. I may reject the kidney. I may have a surgical complication. So if you have those expectations beforehand, you sail better and you'll feel better. There are some emotional issues, as I said, it's some people feel a great burden of responsibility caring for the new kidney. Can require a lot of efforts from the patient. You have to realize that there is actually a complex medication regimen, frequent blood draws, frequent visits, as we talked about. Complications often happen, so you should be prepared for it. So there is a lot of and a great deal of responsibility that come, and that can actually cause some anxiety and frustration. So be ready, set low expectations so you do better. And something I've seen as well extremely that can happen. Actually, no one talked to you about is some patients do not realize that they may feel some guilt after successful transplant or unsuccessful transplant if something happened, if they deal with complications, especially if they get kidney from a living donor, from someone they know or a loving one. Dealing with complications if the kidney does not or reject early on, having that guilt, the guilt of also getting kidney from a deceased donor, whether to contact the family of that deceased donor or not. This may actually sometimes create an internal struggle. I've seen that happen. Not frequent, but can happen. Issue may come up, so you need to be prepared for it. It is important actually to talk about these things before they come up, okay? And as I said, if you can be the most compliant patient and complication can happen, so be ready. Sometimes, people get surprised why they still need dialysis in the first week after transplant. They receive a deceased donor kidney that's lazy to pick up. Most of those kidneys, start to work, sometimes take a week or two of dialysis, so they can get a little bit of frustration, and that can lead to anxiety, exacerbation of underlying anxiety or depression. So it is important to know that complications may happen, and it's no one's fault. It's no one's fault at all, So how to improve your emotional health and how to cope with all those issues that may come up.
Dr. Issa, we have about 10 minutes remaining in the session and approximately 10 questions.
Excellent. Can improve it, involving your family and friends early in the process, very important, managing your expectation. It's very important. There are some financial responsibilities that people do not know about. Medicare will end 3 years after transplant if you're under the age of 65 and you have Medicare because of dialysis. The good news, recently the law has changed and the Medicare will provide lifetime coverage for medication. The coverage will become effective on January 1st, 2023. So that's a good thing. You lose the other Medicare coverage if you're a Medicare patient coming into transplant and you're under the age of 65. Also, it's very important if you lose Medicare or other, disability, and you be ready to return to the workforce. Make sure you have enough financial stability if you're unable to work and how to apply to disability and such. People who have Social Security disability benefits through dialysis, those can be reviewed within a year and you may lose those. You may lose actual eligibility for disability and Medicaid, so keep that in mind. So let's address some of the question you may ask about the new normal. Oops, sorry, let me go back. So increased energy level, and who doesn't like that, right? So it's good. So you're no more being wiped out from chronic kidney disease or from dialysis. You can eat at your favorite restaurant. Of course, I put COVID-19 precautions, always important because you're immunosuppressed and more prone to infections. You can spend more time with family and friends. You don't have to lose 3 days of your week on dialysis. Travel becomes easier and more feasible. Most people on dialysis know how hard to international travel, almost unheard of. Here in the US, domestic travel can be done if your dialysis unit really set you up. Very important, that transplant will improve your feeling of despair and depression associated with chronic illness and chronic kidney disease. And when you go back to the workforce and you do meaningful things, you contribute to society, that will give most people a renewed sense of purpose. So instead of dialysis constraints, you focus on keeping that kidney healthy. Some complication can happen, but this should not deter you from getting a transplant. I can tell you, despite following all the instruction and being perfect, some people will still have some complication. This is why managing those expectations is very important. So some tips for the best outcomes. Use your resources. We're always here for you as transplant specialists, your coordinators, social workers, any financial issues, transplant pharmacists. Involve your family and friends early in the process if they can come with you in the pre-transplant phase and the post-transplant. Keep yourself well hydrated. Keep the kidney happy with fluids. We'd recommend 2 to 3 liters of fluids per day. Take your meds on time. Plan ahead. Very important. Decide who will help you organize your medication. If you're old and it's hard to do it. Set alarms to remember when to take the medicine on time. We recommend using pill boxes and filling them, especially if there is changes in the dosage. And if you travel among different time zones, ask your transplant team how to time medications. There are some apps now on most smartphones that help you with that and with the time difference among time zones. Now, we'll talk about
5 minutes remaining in the session.
how much?
5 minutes remaining.
Okay, vaccination. Do your vaccination before transplant. The COVID-19 is safe to be taken before transplant. It has been deemed to be safe after transplant, but you're probably aware that not everyone can mount an immunity against it, so it's better to do it before. When to contact the transplant center? When you have an increased creatinine, so maybe rejection is happening. New onset protein in the urine. If you have any question on reduction of immunosuppression, don't stop your prednisone. Some people do it. If you're starting new medication or over-the-counter medications, if you have any recurrent infections, we can help you with uncontrolled blood pressure. If the BK virus is detected in the blood, and if you have any question, you should call your transplant center. So it is very important to know that transplant is a treatment, not a cure. It's the best treatment. It's include a lifetime commitment. It improved your survival. The more educated, the best outcomes. Incorporating healthy diet and exercise before and after is very important. The emotional burden of receiving kidney can be overwhelming, but it is actually still a life-saving endeavor. Knowing what to expect and managing your expectation early on are key. It's important as well to have family and identify family members and friends who can help you throughout the new normal. Complication may happen. Don't take it personally or feel you have done something wrong. And I'll stop it here. Thank you. Sorry,
Dr. Issa, I have a few questions for you.
Yeah.
Some of them were actually answered in your presentation. So for those of you who put in a question that he did wind up answering, I'm going to start with ones that weren't answered since we have limited time.
Yeah.
One of the ones I think needs the most, the COVID-19 vaccine, what you could say in a little bit more detail about that for people who did not mount any immunity or even those who have weak immunity, what precautions should they be taking?
Yes, I get this question all the time. Actually, every day, 2-3 questions about that. What we know that the response in transplant patient on heavy immunosuppression, solid organ transplant recipient, the response can be actually low to the as low as less than 10% after 2 doses of the mRNA vaccine, one of the main vaccine that we use here in the US, Pfizer or Moderna. But I tell people, you should keep your safeguards as it don't feel like you're protected. Some patients actually ask me to check the levels of the antibodies, and if they're detected, don't get that you have that sense of protection. As a transplant patient, your household should be also aware, and we recommend that they get vaccinated. Now, there is some encouraging news about using a 3rd dose as a booster, or maybe 4 dose or bigger dose. There are a lot of research, and I think the FDA and the CDC will be updating those in the next few weeks. So stay tuned, because there are mounting evidence now that if you give a booster, you may have better response. Outside trials, I do not recommend to get the 3rd until we have a stance by the FDA and the CDC. So I do not recommend to take the vaccine again if you don't have antibodies. Just keep social distancing, keep masking, and keep especially in your enclosed spaces. I tell people, look at your community, look at the county. If you have still high prevalence of COVID-19 infection, if a lot of people are not vaccinated in your community, then don't let your safeguards.
Thank you. I think that does help. There's also a question about there seems to be competing information about just activities in general post-transplant between different transplant centers, et cetera. Do you have a recommendation for what you feel is safe for post-transplant activity and lifestyle?
Typically, like any surgery, the incision is fairly large. So in the first 2 to 3 weeks, we tell people avoid heavy lifting until the incision, because hernia can happen. Incision, if it actually happen and you're on immunosuppression, you can get an infection. So typically you take it easy. You can still walk, do things, maybe like mild jogging. I would say take it easy for about 6 weeks before engaging in heavy and going back to the gym or heavy exercising. So about 6 weeks are enough. Ask your transplant specialist when you see them when they dismiss you from the clinic and say you can go home and you can start doing labs at home. Ask them when do they recommend, depending. So it's case by case, depending on how large the incision, how large is the belly as well. So most people are overweight, can have actually more complication with the incision than people who are not overweight. So, but typically within 6 to 8 weeks, it's advisable to go back even with lifting and doing things the way you did before transplant. Good question.
You did mention something about kidney cancer. There was a question with large kidneys and very cystic kidneys. Is that a concern for that being underdiagnosed?
It's a rare occurrence, but we have seen it. We're at Mayo, we're a large PKD center. we're actually a little bit we see a lot of PKD patients get their transplant here. They come for the bilateral nephrectomy at the time of transplant. So we have seen, a cancer happening that we did not diagnose before. It's a rare occurrence. You should not be, I just mentioned it there. You should not be really worried about it. The cysts themselves do not degenerate or do not actually differentiate or become bad cancer at all. Sometimes there may be, especially people are on dialysis for, 5 years, 6 years awaiting kidney. Actually, normal kidneys, meaning kidneys that are not polycystic, patient may acquire those solid masses that can be renal cell cancer. So the problem, sometimes you cannot give IV contrast if you're not yet on dialysis. But if you're on dialysis and there is suspicion on imaging, we do an enhanced MRI or enhanced an MRI or an enhanced CT scan to look for those. It's a rare occurrence, should not really frighten you. I would say, we rarely see it, but I mention it in the slides.
Thank you. I just got a note that we are at the end of our time for this session. I do appreciate you. Thank you, Dr. Issa. Are there any last comments that you would like to make?
No, thank you so much for the invitation. If anyone needs to, maybe you can share my email if at some point with you guys, you can ask me questions later on.
Absolutely. Thank you for being so generous with your time. Thank you to everyone who joined us today.